Sorry. So again, welcome and good afternoon. So this panel will be talking about social health protection. And hopefully when we finish the discussion, a lot of the terms, words that sometimes color or define how we understand it will be removed. At the end of the day, what we're really talking about here is how can people, when they get sick, get access to healthcare services. There's a term we use in health, universal health coverage. Very powerful word because it talks about universal, right? How many programs in the world talks about universal? Quite a lot. So that means, and essentially it builds on the health for all agenda. And probably you're all aware of that since 1949, then health for all in Alma Ata. And essentially it envisions that every person would have access to needed health services without risk of financial protection. And without risk of financial ruin. And I think that's the key word that's been added. Before, it was all about access to healthcare services. Then the ministries of health are left to themselves. What does access mean? But now it actually says it's access without risk of financial ruin. Because now it basically recognizes that if people, when they are sick, they become poor because they have to spend, that's not good. If you are poor and you could not access healthcare services, that's not good. So that makes it, in a sense, UHC makes it so close to the whole discussion on social protection. So the world has, so countries have done different ways of addressing that. So countries, and in health, we always used to have this approach definition. So sometimes we call it the beverage approach. Okay, so Beveridge is a nice British guy who set up the National Health Service of the UK. And there they say it's because you get your taxes and you operate your hospitals, and he nationalized the hospitals in the UK right after World War II. You pay salaries to doctors, you put up health centers, and then the services will be provided for free, medicines will be free. So basically, direct service delivery. Then they have this German guy called Bismarck, who basically said, okay, there's another way. You set up a separate fund, an independent fund, social protection. Probably this led to a lot of pension funds. So this is the insurance approach, where basically there's an earmarking, there are premiums that are being paid by the workers, and this goes to a fund, and the fund covers or pay for your healthcare services. The provider of the healthcare services basically is public or private. So you could now, when you get access to healthcare services, you don't need to go to a government facility. So and for the longest time, we have this big debate in health between Bismarckian or Beveridge, until you also have the Shemenko model, the Soviet model, they say, where basically everything is controlled from above and you put up health facilities everywhere, all over the country. Now there is an emerging model, quite interestingly, which merge all of them. Developing countries basically was not able to do what Germany did, which was to grow their formal sector to the point that the population was formal sector. So it was easy to collect all these premiums. A lot of developing countries, the formal sector got stuck at 30%. So you get, if you have the insurance to the premiums, they will pay, but what happens to the 70%? And the countries say, we could not just leave them to the direct provision. They could not just leave them to government hospitals, walk in for free. Because unfortunately, for a lot of these countries, these government hospitals had facilities deteriorated. So they found some solution, and they say, let's forget about the Bismarck and Beveridge, they're dead anyhow, and simply combine both. So they started using tax money, government revenues. If you're in the Middle East, don't use the word tax, they don't pay taxes, they say government revenues. And then they subsidize the informal sector, initially the poor, into health insurance funds. So we started calling it National Health Insurance Fund. We call it the Thai model, different models. But in the sense, at the end of the day, I think what's important as we try to understand social health protection, let's unbundle ourselves from that's insurance, that's premium, that's earmarking, and rather look into how protection is actually going to be provided. And that's the story we'll be hearing from our three presenters. We have three countries, Sri Lanka, Maldives, and Philippines. There's no bias here. It's not that I do like to go to Maldives and Sri Lanka, great countries. So I'm already sending a message to Dailin that in their next mission, you better bring me there. And of course, the Philippines, a lot of you are probably based in the Philippines, so they all have great stories on how they're doing it, various different approaches, and it will be a very interesting talk. And Dailin will introduce our speakers now.
Thank you, Dodo, for this very insightful opening. I think this can also serve as the closing, but anyway. Okay, yeah. So our first speaker is the State Minister of Health of Sri Lanka, Dr. Thiha Arambepola. So Dr. Thiha is the current Health Minister of Sri Lanka. She was the former State Minister for Skill, Development, Vocational Education, Research and Innovation. And she was also the governor of the Western Province of Sri Lanka before. So Dr. Thiha is a very active member of various high-level committees of the government, such as the Committee of Making Recommendation on Suitable Government Hospitals, committees on combating COVID-19 during the pandemic. She's also proactively leading the government's policy discussion and initiatives on public-private partnership in the health sector, and also overseeing the country's pre-hospital services. Before being a politician, Dr. Thiha was a well-known ENT doctor and head and neck surgeon in Sri Lanka, who worked in clinical setting in a government hospital for many years. Such clinical experience makes her has an in-depth understanding and know-how about the situation and challenges that frontline healthcare worker is facing on the ground. In ongoing health financing and health system reform dialogues, she also uses her clinical experience, sectoral expertise, and political influence to lead reform forward to enable Sri Lanka to achieve universal health coverage in a more inclusive, sustainable, and responsive way. So Dr. Thiha holds a Doctor of Medicine degree from the University of Colombo and also a Bachelor of Surgery degree from Sri Jayawardenepura University. So let's welcome State Minister Dr. Thiha for her panelist presentation.
Good afternoon, moderators, distinguished guests, and all the participants. I want to thank to ADB giving this opportunity and this amazing gathering to share our knowledge each other. So starting my presentation, I would like to outline few things regarding Sri Lanka. Mainly health system in Sri Lanka, I will discuss in further, health financing of Sri Lanka, strengths of existing health system, challenges, health financing regarding challenges and responses, and measures taken for vulnerable population. So I'll go to the first slide. So this explains a little bit of Sri Lankan medical health system. Sri Lanka holds a unique position in South Asia as one of the first of the less developed nations to provide universal health, free education, including health education, and strong gender equality. So population of Sri Lanka, 22.1, so it varies every year. And we have 9 provinces, and a health sector divided into 26 regional divisions of health services. So if I talk about the system with some achievements, as of today, we have life expectancy of males around 74 and female around 80, and adult literacy rate 91.5, and infant mortality rate 6.4 to 1,000 live births, and human development index nearly 0.71. So with a lot of difficulties, economic challenges, still we are maintaining good indicators. So in spite of other challenges, basically maternal mortality rate, infant mortality rate, and rest. So this is about Sri Lankan map. So we have 9 provinces and divisions of for health management. Mainly, so next slide please. Mainly our health system governed by Ministry of Health and Department of Health. Under that we have 2 sectors, provincial and central or the line ministry. Both sectors provides curative and preventive care. Out of that, mainly preventive care, or the primary health sector governed by provincial governments or the provincial ministries. But both sectors provides curative as well as preventive services. Next slide, please. This is just to have an idea about the hospital setup. From the National Hospital to Primary Medical Care Unit, out of that, 536 primary care units governed by the provincial sector. So altogether, we have primary medical care units 544. So including National Hospital, we have other provincial general hospital, district general hospital, altogether 1,161. So go to the next slide. I don't think I have to explain much about health financing for this audience, but just to complete my presentation, health financing is a core function of health system that can enable progress towards universal health coverage by improving effective service coverage and financial protection. WHO's approach to health financing focuses on core functions: revenue raising, pooling of funds, purchasing of services. Go to the next slide, just about context of health financing regarding Sri Lanka. We are trying to achieve universal health coverage, the goals. So maintaining healthcare free at the point of delivery, reduce persistently high out-of-pocket expenditure, reorient health services to face current and future health challenges, maintain quality of care. So to make health policy just in future to achieve this universal health coverage and the social protection, we are working on 6 strategic directions. Next slide, yeah. Promote aid effectiveness, efficiency and equity of public spending, revenue collection, effective pooling, strategic purchasing, reduce financial risk and barriers to health access for the poor, support resource tracking mechanisms. So in spite of all the challenges, what are the strengths we have as a country in our health system? Explicit health policies and plans, so developed during the last few decades, reaching our goals, that targets of comparatively good indices. So well-organized and well-structured network of curative and preventive health institutions, including vertical programs. That was the main strength to face COVID pandemic during 2020 and 2021. We were managed to mitigate first wave of COVID without any deaths. Because of this strength, we have good structured primary care health service. Also establish infrastructure, norms with good geographical distribution, technically competent and skilled, high quality human resources for health and well-organized training mechanism. That's why huge demand for our healthcare workers, including doctors, nurses, caregivers. Even in developed countries, there's a huge demand for our specialties like anesthesia, gyn obs, pediatric, and emergency care. Technically competent and skilled high-quality human resource for health and well-organized training mechanism, that's what I mentioned, and public reputation regarding health system. They believe, they trust, and they seek help from the health sector, government health sector. Actually, OPD service, about 50% served by private sector, but nearly 50 to 60% by the government sector. But inward facilities or inward treatment, mainly by the government sector. Out of the inward treatments, only 10% is serving by the private sector, but mostly by the government sector, by 10% by the private sector. Because it's totally free care service across the country, so without any limitation for gender, ethnicity, age, or the geographical situation, they get free health service. Low-cost model with high health gains. So the structure and system, the infrastructure, they're developed to give maximum service for the public. Also, direct accessibility for and availability of healthcare free of charge at the point of delivery, as I mentioned. Good collaboration with the private sector, even though it's less percentage serves the inward, but outpatients treatment or the OPD treatments is governed by 50% by the private sector. and accessibility is increased due to this private sector availability. Self-funding of the private sector, active professional colleges and academia. We have nice setup of colleges, like College of Anesthesia, College of Orthopedic, College of ENT, College of Physicians. We have good academia, looking after the education sector, looking after the care sector, looking after the health, the indices monitoring, and so on. Active professional college and academia is a huge strength of us. Organized financing system, support from external domestic donors. So challenges. So we are facing, Sri Lanka is currently facing the worst economic crisis since independence caused by the excessive public debt burden, devaluation of the local currency, and negative economic impact of COVID-19 pandemic. Not only that, so continuing challenges. So, yeah, next slide, please. Yes, insufficient resources for health services, inefficiencies, we have to be honest, whatever the resources we have, if we are inefficient, we won't be able to reach to our goals. Inequities by economic and social geographical factors sometimes with this COVID and other economic crisis, but otherwise geographically setup is nicely placed there since few decades. But thing is, with the economic crisis and this pandemic challenges, sometimes geographical factors are coming up. Need to further reduce catastrophic as well as impoverishing health expenditures out of pocket by individuals and households, public financial management issues, need for greater synergy between private and public actors. So those are the main challenges. I don't want to go further discussing challenges, so because we need time to discuss so among ourselves. So I think there are a lot to do and more to go. So, but we are managing our health sector and health systems thanks to all the professionals, all the care workers, all the staff giving their hard time to the sector. And so policymakers during last few decades, compared to other sectors, with the economic crisis still we are facing the challenges, not it all finished over, but still we are managing our health sector to a certain extent and standards. So, but we know we have to do a lot. Thank you.
Thank you, Mr. So for our next speaker is the Mr. Ismail Azam Waji. So Mr. Azam is currently the managing director of Asanta Company of Maldives, which is the implementing agency of National Health and Social Insurance Scheme of Maldives. He's overseen the administrative and reform of the National Social Health Care Financing Scheme. And prior to his current position, he served as the Chief Executive Officer of National Social Protection Agency for Maldives from 2017 to 2022, providing strategic, financial, and operational leadership and technical support to the agency for implementing its mandate under the National Health Social Insurance Act and Social Protection Act. So as a CEO of the agency, he had actively worked with multiple donor agencies, including World Bank, ADB, WHO, UNICEF, and other UN agencies to introduce and implement major reforms to the social protection sector of Maldives. Mr. Azam also led several critical reforms in the social health protection of the country, including but not limited to the development of social protection information system, the introduction of National Social Protection Framework, and also the establishment of National Disability Registry, and also the preparation and implementation of guidelines and regulatories for major social protection programs of Maldives. He holds a Bachelor of Arts degree in Business Management and also a Master of Human Science degree in Sociology and Anthropology. So let's welcome Mr. Azam for his panel discussion.
Good afternoon, everyone, and thank you, ADB and the regional health team for inviting us and letting us speak and tell you about what we are doing in terms of social health coverage in the Maldives. I hope I will be able to keep it short as much as possible. And let me just jump into few of the elements. Next slide, please. Few of the elements that I'll be discussing today. One of the things that I thought I'd start with is talk about the background, or just give you an idea of what Maldives is, because compared to many other countries present here, as well as that are represented within the summit, I think we have a unique as well as a very different scenario in terms of where we are in social health coverage, as well as how we are placed as well. And I'll go into some of the challenges that we have, as well as just as final slides, I'll introduce some of the ongoing developments that we have brought with expert advice from ADB as well as World Bank in different settings in historic consultations that we have had. So going on to the first slide, just next slide, please. Now, we started healthcare financing in its modern sense, or in its current sense, since 2009 onwards. And we started off with a program where all civil servants were enrolled into a contributory kind of mechanism where government decides to pool those funds that they were spending on the civil servants as medical allowances. So this pooling of funds was the initial birth of health service provision for in a structured manner in 2009. However, since then, a lot of development has come into the whole architecture of the program, as well as the coverage as well. So as you can see, there's a huge hike in 2012. This is where we introduced the universal healthcare financing program for all Maldivians. So currently we run a program where all Maldivians are by default enrolled in the National Health Service financing program under the National Social Health Insurance Act. And in the first year itself, we had now the numbers that you see on the green line is the population that is covered, or the coverage that we have in terms of service, those who have sought services. And the yellow color is how much we spend on these, and the gray is basically blocked transactions. So as you can see, in 2012, when we started the program, we had about 275. This is in thousands, okay? 275,000 people enrolled and utilizing the service in the first year. And we were almost spending about 100,000, as you can see, as expenditure. However, today, or the last representation that you see, in 2021, if you compare, we have about 350,000 people enrolled in the program right now, and we are now spending close to 1.5 billion as expenditure on the scheme. Next slide, please. Now, when we look at the 1.5 billion, the largest chunk that we are spending on is on pharmaceutical outpatient care. Now, this is very weird for a lot of, this might come as very weird for a lot of you who have social health insurance programs, but Maldives being a country where there are a lot of limitations of getting services locally, and being a country where we don't produce any local medicines, especially not having a local or traditional medicine element either, limits us to pure usage of imported medicine for all health services, including flu, including anything that happens to you, backaches, even cough, everything. So we don't have a lot of traditional remedies for many of these things, which is a problem right now. And because of this, there is a huge consumption of imported medicines through pharmacies. This is prescription-based usage of or consumption of medicines that are from outpatient pharmacies. So if you can see, there is about next, can you please press the, yeah. If you can see, I'm not talking about a little difference. Now, this is like 54% of the whole cost that we are spending. So 1.5 billion is inclusive of overseas as well. Now, we actually do not have very advanced tertiary care services. So we employ the services of our very good neighbors, including Sri Lanka and India, to get the actual treatment for patients who require surgeries or complex surgeries or advanced tertiary level or quaternary level care as such. So this number that you see is inclusive of travel and getting the treatment from abroad as well. So for all those, we actually spend about 13%. And compared to that, this 54.8 is something that we indeed are trying to somehow, manage and try to bring down. So this will be one of the key targets for us in the coming years. We have accessibility ascertained. We have measures to make sure people can afford and access, and the out-of-pocket is currently under 20%. From the 40 that was there in 2012. So we are indeed making it possible for people to get healthcare. However, the cost of it is extremely high. So this is just a representation of how or what we are spending on. So inpatient hospital care locally is about 16.5%, that's 257 million. And for clinics in the capital as well as other cities of Maldives, we are spending about 6.9%. And opticals, we have a program where people have coverage for every 2 years for spectacles as well. So this costs us about 2.2%. And airfare tickets is purely on sending people abroad on the overseas program. So that's about 2.7%. And then we have a mechanism that allows Maldivians to travel from one facility to the other for emergency evacuations as well. So if there is a requirement for you to be taken to a higher facility, we actually pay for that and make sure that the arrangements are there as well. So these cost us about 1.3 to 1.7 as well. So imagine having all those, yet the largest that we have in terms of the cost center is actually the pharmaceutical. So next slide. Just to let you know of the dynamics of what we have just been discussing. Now, the 350 coverage is from 382,000 population. So we have a population that is very small, and the conventional health insurance, where you pool funds and you cater for, get contributions and cater for the services that you require through such elements, are not really something that is very easy for us in terms of the number of the population, as well as the high cost of health service delivery that we have. It requires a lot of other elements to be added into it as such. So for the 382,000 population that we have, can you press the button? Yeah, once more, please. Now, the 382,000 does not live on one piece of land. Now, this is the largest challenge that we have in terms of making sure accessibility and making sure that people can access health services or health services are available on their local islands is the biggest challenge that we have. Now, if you look at the pie chart there, what this tells you is basically there's only 4% of the population that lives on an island that has more than 5,000 people. So one island with 5,000 people or more is 4% of the population. The rest, especially the under 2,000, is about 70 or close to 74% that lives in islands that have less than 2,000 people living on the whole island. This is inclusive of children, inclusive of elderly, everybody. So making health services possible for the 198 islands that people live on is a huge challenge for the government. But because we are committed to making sure that health services are available, that everybody gets free health care, everybody gets quick services to health care, we have health facilities, government health facilities on each and every single island of the Maldives. We have pharmacies, state pharmacies in each and every single island of the Maldives. So this has a huge cost burden for us. And when you see the usual map atlas, you will see that Maldives is sometimes on it, sometimes not, because of the small size that we are. when you zoom into it, you find this blue color, dotted structure, which is the Maldivian usual, what you see as Maldives. But if you zoom into it, you will realize that this is not the actual islands. So what you see on blue are not land. It's purely sea. When you zoom into it, you see that only the outer ridges are actually above or closer to 1 meter of sea level as such. And from that ridges, only the black color dots that you see, the gray is again water. So the black color ridges that you see with the name is the only dot of, or the dot that people live on. That is what you see in the picture. So the green color, the islands, are the black colored dots on that zoomed picture. So you can imagine there are 198 little islands like that, where as a country, as a nation, we are committed to make sure that they have proper healthcare, have accessibility, and make sure that they don't have to complain on seeking healthcare from the nearest facility either. So just to give you a picture of how it looks beautiful, but as a government, providing these services is a huge challenge for us. Next slide, please. Now, like I said earlier, one of the key challenges right now that we have, after making sure that everybody has healthcare, there are health facilities on the islands. The second largest issue that we have right now is in terms of universal health coverage. We have covered all Maldivians. Every single Maldivian in Maldives will have accessibility as well as free healthcare. Catastrophic healthcare expenditure would not be an issue because there are multiple programs, plus there are avenues for them to appeal if they don't get any service that is due for them as such. However, as a residential, when we compare population health, it's important to see the residential distribution as well. So we are not just talking about Maldivians. Can you press the, yeah. So if you look at the total population of Maldives, this is about 515,000. Out of that, about 132,000 are actually foreign personnel working in the Maldives and living on one of these 198 islands. So some of them may be in the small islands, some of them may be in resorts nearby, some of them may be in the capital. But this 132,000 is mandated to have an insurance for work permit purposes. However, what we see right now is the extension of coverage is something we want to make sure is available for residential populations beyond the inpatient care that is covered usually in the existing mandatory health coverage requirements that we have in the country. So what happens right now is foreigners working in some of these islands, if they want to get access to healthcare, they will have to go to a facility where the healthcare is available. Now, accessing that is usually not covered under any health insurance program. They will not give you the transportation requirements or the money that is required to get yourself to the health facility kind of thing. So we are trying to bring that element of accessibility into the full range of population that is living or residential in Maldives at any given point of time. And this is mainly because of one reason, which is the majority of these, the labor force is where, getting them healthy keeps our economy good as well, and making sure that they don't bring in or even get a mechanism where identification of diseases as soon as possible allows us to minimize transfer of diseases to the general public or residential to Maldives as well. So it has that element of managing healthcare cost at the end of the day for the whole population, since we are already paying for any ailment that or any diseases, any ailments that requires healthcare financing. So that is the general requirement that we have at the moment on that issue. Next, please. The third one that I would like to look at is in terms of coverage, we actually do cover all major, from flus to transplants is all covered. So there is no health service that the doctor requires or has prescribed to you that we will not pay for. And that is good in a sense. However, locally, whatever services that we have available have very limited standard guidelines or treatment protocols. Now, this is a huge risk when you look at it from a sustainable angle, because getting it available is one thing, but the moment that we start paying, now we are paying in 2019, as you can see, we are paying that much. And if it continues as is with no controls on what to prescribe, no controls on what procedures to do, now people have a tendency, it's either intentional or unintentionally, medical professionals would also like to look at all possible angles. Now, somebody comes and complains of some certain things, you might want to look at many, many things, but usually what happens is if that person cannot afford or cannot have the luxury of paying for those extra tests or extra procedures, just to be sure, they try and make do with whatever limited or only necessary tests or only necessary diagnostics would be run. But in a country like ours, where they know everything will be paid for, everything will be covered, you would rather, tick all the boxes, do all the tests that is possible, then we'll see whatever potentially comes out. So this is a pattern that we are seeing right now. It may be unintentional, in the sense, it's good for the patient either way, but however, as a financer, this is a huge risk for us. So one of the key elements that we are trying to do is, with the necessary stakeholders, have mechanisms of ensuring that there are standard treatment guidelines, there are treatment protocols, so that we know what we have paid for is what we require to pay for, per se. And the second thing that we have, the fourth thing that we have is health-seeking behavior and the local service market. Now, local here, I'm referring to as a country which has a lot of tourists from all over the world, and with extensive access to internet services and all such services, Maldivian patients have the luxury of seeking out where these services would be available across the world. So now there is a demand for us to, empanel more places, per se. Now we provide it from India and Sri Lanka because it's nearby, and we started off in that manner. However, there are some services that, would be less invasive, less painful, less, many things, if you were to do it in probably Turkey, or probably do it in Thailand, or even Malaysia, or even Singapore. So there are demands that come out. Now, these are not something that we are too worried about as a company as such. However, since Maldives is a very small country, and since these are generally based on what we provide are generally based on the demands of the public, any election cycle will ultimately have that pressure from the public to have these empanelments as much as possible. So one of the key challenges that we have right now, we're not looking at limiting it as such. However, we're looking at paying for what is equivalent to what we would pay for if we were to do it in the nearest facility, kind of thing. But to give them the option, because Maldives is not, our poverty rate in terms of, you can see on the diagram, our poverty rate in terms of our national poverty line is also under 5.4%. So this is 71.4 rupiah per day. And if you look at the US dollar, $5.5, the usual upper middle income countries are gauged on the $5.5 poverty line, and we are actually with a population that is 1.7%, who is below that $5.5 per day per person poverty line. So we have a population that is affluent, that has the ability to pay for a lot of these things. So limiting their accessibility to go and seek services elsewhere is not really something very attractive for the whole population. So what we are trying to do is make sure that the national coverage is fixed or is defined, predefined in terms of what service, what healthcare requirements that they have, and open it up as much as possible in terms of with proper referral mechanisms, with proper mechanisms of reporting as well as data management as well. So like I said, traveling abroad, again, is not a challenge because sometimes taking a flight from the capital, Male, to the southernmost point takes more hours than taking a flight from the capital to Sri Lanka or to go to Trivandrum as such. So accessibility, and there are many flights available and all those things. So because of these reasons, we do have interest towards making sure that there are better mechanisms to standardize what we require, and better mechanisms to record and keep data available on the diagnostics and all those things before we start such a thing in the future. Next slide, please. So ongoing developments in terms of the discussions that we have heard from many other countries earlier on as well. One of the challenges pre-COVID was to get people to really use online platforms. Now people walked into hospitals, then only they decide, or then only they request services per se. But luckily for us also, through COVID, a lot of the public learned on how to, and moved on to start utilizing online applications and online tools so that it brings down our cost in terms of managing the system, plus proper referrals and proper mechanisms of getting the doctors to actually issue live transactions in the system, so that we know that somebody would be coming and somebody would require a certain thing or service beforehand as well. So currently what we have is we have digital mechanisms for doctors to fill referral forms and submit it to the system. And also individuals who have appellant requirements can actually apply on their own through digital mechanism. When I say digital here, I might not be right on the actual term, but when we started also, we have mechanisms of submitting signed documentations. But right now, what I mean here is they don't have to print anything, or they don't have to sign on anything, and they can actually sign into our national single sign-on mechanism and then apply through the actual app without having the requirement to scan or sign anything, print or sign anything as such. So fully digital in that sense. So paperless in its full sense. So that is something that we have started. And also, like I said, our largest cost center is pharmaceuticals. So we've started medicine price revisions and price harmonizations across the generics, as well as price controls comparative to wholesale and retail prices that are available in the market. Now, one of the challenges that we have is that we have public plus private sector participation in pharmaceutical disbursements, and it's almost equivalent in terms of percentage of importation of pharmaceuticals as well as availability or outlets as such. So we have about 180 public pharmacies and about 180 private pharmacies as well. So the whole market previously was not controlled, and we don't have an MRP like the India. We don't have cost controls on medications at all. So importers are able to sell at any price that they want right now. We have a contractual agreement on controlling price for empanelment purposes, but it does not disallow them to sell the same medicine to the person out of pocket at the end of the day. So the out of pocket still remains as a 20% because of this reason. There's a huge avenue for pharmacies as well as clinics and hospitals to charge out of pocket at a rate that is not controlled. So if they come through Asanda, they'll have to pay the fixed price per se. So the other initiative that we have is in collaboration with the Ministry of Finance, Ministry of Health and MFDA, as well as Asanda and STO and UNDP, we are trying to procure some of the medicines that are commonly required for the Maldives and bring down that cost in terms of what we have to spend. And the last thing that we have is we actually have introduced a new pharmacy module. Now we have digital disbursement processes, and all the pharmacies within the Asanda system has to issue pharmacies through our portals as well previously. However, we have brought new changes to the portal, new changes to the module, introducing several controls as well as comparative tools where the module will tell you, the pharmacies as well as inform the person collecting the medications, that whether they have the same medicine issued to them in the recent past per se. So there is a percentage of duration where you can get it refilled. There's a percentage where you can't get it refilled. So what happens right now is you go to the doctor today in the morning, and then in the afternoon and the evening, you get 3 prescriptions, you go and get the 3 prescriptions filled free as well. Because it's free, everybody doesn't really complain about it. We are the only people who have the burden of paying for them. So now we've changed that, said, if there is a repetition of the exact same thing, we're not going to be issuing it to you. You have to, buy it on your own, or have the doctor tell us that this is something this person really has to use because this person has a negative or has some sort of ailment that disallows him to use certain medication. So that's one thing. And also medicine receiving confirmation. Now this is one thing that we have introduced in terms of making people aware of how much is being spent on them. Now, because it's free, because nobody knows how much is spent on them, they just take the medicine and go. And this will be a huge bag of, medicines, which they don't really realize has a monetary value to the whole thing as such. So some of these medicines are really expensive medicines. And because of this, now we have the mechanism of informing the person who comes to collect it and validating that they are the one who is collecting it. And then, make sure that the code that they receive is used for disbursement as well. So they will not be able to disperse to just whoever comes with the prescription, but you have to declare yourself as the one collecting it, and then there is a message at the end of the day that tells you how much has been spent, what has been given to you as well. Next slide, please. So in terms of the general discussion, I think I've taken too much of the time as well, but in terms of going forward, I'll be more than happy to answer any questions as such. And you're always welcome to come to the Maldives, and we base our economy on tourism. So, visit Maldives anytime that you come. Thank you so much. Yeah.
Thank you, Ms. Assam, for this very insightful presentation. It's also a very frank presentation as well. So let's welcome our last panelist speaker, Dr. Clem Bautista. So Dr. Bautista is a medical doctor and a career officer of PhilHealth. Currently, she's the acting senior vice president and lead the Universal Health Coverage search team of PhilHealth, working on new health policy in relation to the implementation of this UHC Act of Philippines. Dr. Clem was in the forefront of initiatives on developing standards on healthcare provider, health technology assessment, policy research and development, quality management, organization development, and corporate planning. She holds a medical degree and postgraduate experience on organization development. She participated in various courses and abroad, here and abroad to gain skills. And also knowledge on social health insurance and quality assurance in healthcare. So let's welcome Dr. Clem for your presentation, please.
Thank you, and good afternoon to all, to everyone, and thank you to ADB for inviting us here so that we could present to you what PhilHealth has been doing in terms of the fulfillment of the UHC law. I am from PhilHealth, or the Philippine Health Insurance Corporation, which is a GOCC, or a government-owned and controlled corporation, which is administering the National Health Insurance Program for the Philippines. And my presentation will be in this outline. I'll be presenting a brief background of the Philippine health systems, the challenges and the hurdles, and the Philippine Health Insurance Corporation, its role under the UHC. And also, I'll be giving a short discussion on the PhilHealth mandates and the ways forward in relation to the UHC Act, and how PhilHealth is mandated to sustain the PhilHealth reforms. As a brief background, the Philippines has a population of 112 million. And as to PhilHealth, we have currently a registration rate of 92%, which is about 101 million. And most health indicators in the Philippines are improving except for TB. And the current out-of-pocket expense is at 42%. This, next slide, please. Before that, okay. Just to give you background on the challenges of the Philippine health system, and which we try to address with the UHC law. First is that there is a highly fragmented system wherein, in terms of the governance, we have a local government code in the Philippines which decentralizes the functions of the health to the local government unit. It used to be that this is centralized to the Ministry of Health. And financing-wise, there are still some double financing of some individual-based health commodities, and which is still being funded by the Department of Health. And some government funds for health are still not pulled in PhilHealth, but this is one of the objectives of the Universal Healthcare Law, that the PhilHealth will have to pull all the funds together for leverage. And that there are also multiple gaps for the LGU based on the DOH Local Health System Maturity Model, which includes several key result areas, which will, and indicators and evidence of compliance to check whether they have a mature system or health system. Majority of the provinces did not display maturity in key result areas, namely unified governance, the strategic and investment planning, financial management, information management system, and service delivery. Also, another challenge for us is that there is low financing for primary care. According to a study by ULEP, the benefit payouts from 2015 to 2020 is only an approximate of 9% of the benefit payouts of the entire benefit payout of PhilHealth. And while the total spending for 2014 to 2019, 12% only goes to ambulatory services and preventive health care. And also another challenge is the suspension in the premium increases for PhilHealth, which is already in the law or in the UHC law. Well, this is primarily because of the issues in the pandemic, so that in January, the Board of Directors of PhilHealth affirmed PhilHealth's compliance with the directive of the President of the Philippines to suspend the premium rate increase from 4% to 4.5%, and the increase of the income ceiling from 80 to 90% in CY 2023. So other than that, the premium also for the OFW, or the Overseas Filipino Workers, is now optional. And next is that we have low coverage for catastrophic spending. According to the National Health Expenditure Survey, 30.3% of Filipinos experience catastrophic spending in seeking inpatient care. And this result mainly from the low support value of the all case rates. And according to the National Health Accounts, the government only covers 37% of the current health expenditure in 2021. And as I've mentioned earlier, the out-of-pocket expenditure from the same year is at 41.49%. And additionally, there is also lack of cost-sharing policies and a lack of enforcement of the no-balance billing policy of PhilHealth. Although we have Z benefits, which covers catastrophic illness, there is also limited access, and currently we are reviewing these benefit packages. Next slide, please. So to address the challenges of the health system of the Philippines, the UHC Acts mandated reforms which aim to fill the gaps of the UHC cube in terms of the membership coverage, service coverage, and the financial coverage. So that for expanding the membership coverage, this is what we are doing right now. In 2019, we have a policy on immediate eligibility, meaning member registration is no longer a hindrance to receiving coverage. There is now registration which is allowed at point of care. This is both in primary care facilities and inpatient care facilities or the hospitals. We are also working on the expansion of the coverage for outpatient services and the inpatient. So we are developing the comprehensive outpatient benefit package, which will include an expanded primary care services and currently not covered services like outpatient drug benefit, emergency care benefit, and specialist outpatient benefits are being worked on right now. And this is supposed to be rolled out in 2025. We are also working on the diagnosis-related groups to replace the current ACR or all case rates. No? And this would mean an expansion of the inpatient diseases and procedures that will be covered by PhilHealth. And also an increase in the coverage for the catastrophic conditions. Next is that in terms of financial coverage, we are working on the new payment mechanisms, which are basically prospective payments and cost-sharing reforms. So for prospective payments, we're working on the development of the global budget, wherein we will be front-loading some amount to the facilities. In this time, we will be contracting healthcare provider networks to receive the global budget. And also, this includes bigger capitation and per diem, and all of these payment mechanisms are coupled with pay-per performance. We're also working on cost-sharing reforms, wherein we will be setting fixed co-payments or co-insurance rates per benefit. For the Z benefit, which is a limited coverage, this will be merged to the DRG system. The global budget is said to or seen to be improve the cash flows of the hospitals and other facilities, and that there would be an improvement in the turnaround time of the claims processing. Next slide, please. So in order to sustain the UHC reforms, PhilHealth is also implementing supporting mechanisms such as the following. For financial sustainability, we're working on the gradual increase and in premium collections and efficient premium collection. Also, there is a revenue we get revenues from sin taxes, and these are the ones used to pay or use as the premium subsidy for PhilHealth for indirect contributors. We also have actuarial study for benefit packages, which we regularly conduct for each benefit that is to be launched by PhilHealth. Prospective payments also has cost containment mechanisms in it, and that we also would want to improve fund pooling. This is by the financing of individual-based commodities by the government agencies or the national government to transfer to PhilHealth. And also we have in the UHC law other funds coming from the charity agencies and gaming corporations, which is the PCSO and PAGCOR, to be transferred now to PhilHealth. Apart from that, for fund mobilizations, we are going into network contracting. We will be paying the PhilHealth payments prospectively to the network or the network managers, which are actually the local health boards and the managing boards of the healthcare provider networks. So this will incentivize the formation of the networks in the local government, and that this would actually induce the integration of services or the local health system development. The ACPNs, or the healthcare provider networks, tasked with managing the money for all facilities, will be tasked to manage the money for all the facilities within their network. And the role of PhilHealth is to monitor the fulfillment of the contractual obligations and fund utilization, so that we will be able to ensure that the healthcare provider networks are complying and providing the funds also to the different health facilities that they cater to. Lastly, the utilization of IT systems. IT platforms are also being developed by PhilHealth to improve the benefit payments turnaround time, and also it will include fund management and M&E. It will be helping us to enable the conduct of the monitoring and evaluation. ICT support is also being sought for the local government units. So I think that's my last slide. Thank you.
So thanks all the speakers for very informative presentation on the health financing and social protection status of each of the country. So for this session, we will have one question for each of the panelists, and then we will open the floor to a Q&A. So I want to raise the first question to Dr. Siha from Sri Lanka. So I understand that Sri Lanka is providing health service for everyone free of charge. However, the out-of-pocket expenditure, as per your presentation, the OOP is still very high. Actually, it's almost 50% of the current health expenditure. At the same time, the size of government budget or government resource for health service is also very limited because of the financial crisis and also the low economic growth. So what is the ministry, or what is your solution to address this issue by lowering the OOPE while still using already exhausted resources to sustain the health care service to the general public? Thank you.
Yes, Dajin, thank you for the question. So I think you have compared the private sector and the public sector. So out-of-pocket expenditure and the free health. So if we consider about the universal health coverage, main thing is whether we can cover all citizens with accessibility and quality. So health protection means whether citizens can get their health service without depending their financial status. Am I correct? Yes, okay. So depends that statement. So how Sri Lanka try to do health protection. So it means accessibility, quality, needy health services. So as you mentioned, yes, 50% of outpatient care or the OPD care looks after by the private sector. That's not because we don't provide through the free health sector, because of demands that people have. Maybe the queue, maybe the transport, the distance, maybe the preference of doctors, maybe the preference of the treatments, the outlook, maybe that the sitting facility, maybe the cafeteria, maybe the child care, likewise. But each and every person in Sri Lanka, either they are in north or south, so they can reach to their medical center with acceptable time. So, and they have a lot of trained medical professionals there to treat them. But thing is, private sector has created a demand, and so they have given their service with different accepted. So different outlook. So, but still we serve all the citizens with the free health care. It's true that because of the economic crisis and other issues, we are struggling with supplying medicines, we're supplying with medical surgical equipment. So other than that, because of the brain drain, so we are now struggling with professionals, the doctors and nurses. So I think, so we have to maximize private health sector by facilitating people how to maintain their OPE. So maybe likewise, the Philippines, maybe Maldives, so we can support with health insurance. But keeping our free health sector intact. We can't just sacrifice our free health sector because of any health policies, because people are getting their service from north to south and other into west to east, so by getting that free health sector. But at the moment, government also looking forward to enhance and so that facilitate private health sector across the country, just maintain the out-of-pocket expenditure in lower rates. So looking forward to enhance that schemes, but still I want to highlight that we are looking forward to keep our free health sector intact and providing more accessibility, more centers, and so providing more services to increase the accessibility.
Thank you, State Minister, for your kind response. So my second question is to Mr. Asan, Managing Director of Asanda. So as you mentioned in your presentation, health service provided through Asanda is actually free and also very generous to all the general publics. So in that case, how can Asanda or the government make people aware that they're actually spending money, although they are not really spending from their own pocket, but they're actually spending the money? How to improve their awareness by awareing that they are using how much health financing resource, and also how to improve their awareness regarding this accountability. I heard that there are some very innovative initiatives in Maldives is led by Asanda to improve that. Would you like to share that?
Thank you. Yeah, I mean, one of the challenges that we have had historically is, like I mentioned, and also like you've mentioned, patients do not really know how much healthcare cost per year for them has been historically. So this puts them in a situation where they start, hopping, doctor hopping kind of thing. So you go from one doctor to the other, you're not happy with the response that the doctor gives. You go to a different person and, do a consultation, try another medication. All these things are there because they don't have, the health seeking behavior is not led by the cost because we pay for the services. So because of this reason, like you mentioned, we've started now to introduce a new mechanism where digital technologies are used to manage as well as inform them on what they are consuming as such. Now, one incentive that we are putting is they can access their own health records. They can see their prescriptions. They can see their, details. So this incentivizes them to get on the app. Once they get on the app, what we are putting on them is we are developing a data repository for health data that we have. And we are putting a new element where your expenditure is displayed along with how much expenditure is there for your age group, as well as how much expenditure is for the total population for the same services. So just like I think Google is doing the same thing, Apple is doing the same thing on the managing health. The health app gives you an indication of other users and that comparativeness. So we are trying to do something similar where you give them a digital platform where we place you and then show you where you are in terms of the rest of the population and your age group as such. So we are trying to aware them on areas that they need to be concerned about. Now, if they're spending too much or if there is something different, obviously this is curiosity that leads to the whole finding out whether there is an issue or not. So we are trying to give them the avenue of utilizing that curiosity and getting into the details. So once you press on it, you can then go into the details and see what is wrong. And awareness elements be put into it where you can look for specialists, you can look for services that are available for treatment of those diseases in different levels of care as such. So instead of going to the same doctor over and over again, they will be also able to go and see whether when there is a referral made for them to really go and seek tertiary level or seek healthcare instead of just waiting for the, and eating the same medication as such kind of thing. So I hope that answers the question. Thank you.
Thank you, Mr. Aslam. It's a very innovative initiative taken by Asanda to really raise people's awareness on the cost of the health expenditures. So my third question is to the acting Senior Vice President, Dr. Clem of PhilHealth. So as per your presentation slide, we understand that Syntax is also one of the source of funding for supporting PhilHealth. Actually, there are many countries, including Sri Lanka, is also exploring how to mobilize this kind of resources to improve the revenue generation of the health sector. However, one of the common challenges that sometimes finance department or finance ministry, they do not want to earmark any tax for health sector. So I know that the Syntax in the Philippine context is earmarked to the health sector, to PhilHealth. Would you please share the story, like how you push the mutual finance or finance sector to agree with this? Because I think that would be a very good lessons learned and can be also adapted in other countries' setting. Thank you.
Yeah. Although I was not personally involved in the development or in the development of the law, but I think there is an already good relationship between the Department of Health and the Department of Finance, and that they did this together, and that each understand why we need this in the country. So I think, and they together convinced the legislators, and I think, and pretty much no one will disagree with the cost of improving the health system. It's a common goal for everyone, and so with a good cause for this money to go to, then I guess that's the reason why this was pushed through. Of course, with the support of the different ministries involved and the legislators.
Really, the awareness and also the buy-in from the financial sector will be very critical to push this forward. So may I know whether there's any questions from our audience? I think we have 5 minutes QA. Yes, please.
Thank you so much. A very quick question to all the 3 panelists. Given the fact that persons with disabilities face barriers in accessing social health protection, any specific measure taken by the respective governments to ensure that persons with disabilities don't have to have any kind of out-of-pocket expenditure or catastrophic health expenditure? Any specific measures? Thank you.
Thank you. I think in terms of Maldives, we have under the Social Health Insurance Act, it's stipulated in the act itself that whatever health systems that we have, whatever coverages that we have, irrespective of the that, PWDs and persons with disabilities are eligible for free healthcare. So even if we have contributory mechanisms or contributions to be taken, they would be exempt from such. Currently, we don't charge anybody, so we don't have it. But even if we were to go to any other mechanism of health service delivery or health financing, we are indeed hoping to have a 3-tiered mechanism in the future. So even when we go to that 3-tiered mechanism, PWDs indeed will be exempt from requiring to pay, and catastrophic health expenditure would not be a deterrent to them to get healthcare in Maldives.
For specific actions for the Philippines, currently we are, of course, developing as I've mentioned earlier, developing reforms in the financing. Specifically, we wanted to increase the coverage for the health services, like including more diseases and procedures by way of doing the DRGs or the disease-related groups, wherein we expect that there would be a fair reimbursement rate when we are done with the development of the DRGs. And also we wanted to fix the co-payments or the cost sharing, and that would help improve the out-of-pocket expense of the members.
Yeah, in Sri Lanka, so as I mentioned, so we are giving free health for all. But when we talk about people with disabilities, it's deaf and dumb, maybe occupational disabilities, maybe other cognitive dysfunctions. So even though we are treating them free of charge at the delivery center, more than that, so they have specific centers. For disability, we have disability hospitals. So deaf and dumb people, so they have their treatment specialized care centers. Other than that, when we go for hearing defects, we do cochlear implants free of charge in the free health sector, providing the devices as well as the surgical facilities. Likewise, they get a lot of benefits through the free health service other than other citizens because of their disability, their requirement. But so I think that as you are expecting to have a specific line for them, specific treatment channel for them, I think every country, each and every country, not only in Sri Lanka, even Europe. So we have to improve that inclusiveness of disability. I think so whole world looking forward to do that. Yeah.
I think we can have one more question from the audience. Anyone? Yes, please.
Yeah, thank you. All the presentations were very interesting. Not so new on the Maldives presentation, but the main question I would like to ask from the panel is sustainability of these schemes. What are the plans for future sustainability of all the schemes that you have just presented? Thank you.
Thank you. Yeah, schemes. What is physical sustainability? Yeah. Since ministers from Maldives, maybe let the other country to answer first. Actually. Yeah.
Okay, I just, yeah, and thank you, State Minister Malik. In the Maldives, indeed, we do have a lot of plans for the future because we are very different from other countries in terms of what we need to achieve per se. Sustainability is one of the challenges, and also I think our biggest issue is the high expenditure that we are having in terms of making sure that this service is continued. So unlike paying for new services, it is very difficult to stop something or limit something after you start something. So this is a very different scenario in Maldives, and it's a very difficult situation, especially the political environment as well as all these things does not allow very quick changes or very quick actions to mitigate future sustainability risks in the shorter term as such. So, I mean, Maldives has a totally large, and we will probably spend a lot of time talking about it, and there is a lot of things that we need to do. However, I'll just leave the floor to, because Minister is from Maldives, so just for the rest of the people, I wanted to say it. Minister already knows this, but I mean, I will let the rest of the speakers speak on their countries as such. And for the previous question on persons with disabilities, actually Maldives has also has a separate program on assistive devices and mobility aids. So we do not just give them healthcare, we give them whatever is required in order to make sure that they are able to actively participate in the population. So all these through the free mechanisms of the government as well. Yeah, thank you.
For sustainability of the program, of course, we have to be improve our collection efficiency, and also there should be cost containment mechanisms. This we plan to integrate in our provider payment mechanisms. Basically, that's what we, and continuously we review our financial positions through our actuary, and continuously working for increasing the fund source for increasing the funds, and looking for fund source for PhilHealth premium, especially for the indirect members or the indigents.
Not that involved in policy making and things about the syntax, but as a country, Sri Lanka is looking forward to how to mitigate that alcohol, maybe tobacco, whatever the things that health burden, to reduce that health burden using those items. While doing that, I think Syntax is doing a marvelous job how to enhance our health accounts, so health finance, and while doing that mitigation of the bad habits in younger population. So I would like to know something about that Syntax.
Thank you, State Minister. I thought I'm just here for the picture taking, so I'm just being quiet. But nonetheless, I think it also means before we get kicked out. I think the question that was asked before I respond to that is social health protection, how do you extend coverage? And frankly, as all those who are listening, for me, you have to take lessons from all of this and you combine it. Sri Lanka, our State Minister said, when you do this, you have a clear objective, free health access. So that means government should have that. When they start to do any of this, they should know in their mind what they're supposed to be doing. So whatever their approach, if the target is free healthcare access, that you're protecting the poor with that, then that should be clearly defined in all the objectives. Maldives, more than anything else, basically said that health literacy means that the population should also be involved in this. It's not something that you expect a benefit or access, then you just forget about. So you really need to, it's not, so empowerment means health literacy, and literacy not just on your health, but also that this is something that we all have a stake, so we make sure that this is not inefficient, not wasted, and we don't abuse the system. Clem was talking about managing healthcare providers. So it also means that the healthcare providers have to behave. In a sense, the Philippines recognized that they could not do this using only the government healthcare providers, but they involved the private. Philippines is 50% hospital beds private, 60% of hospitals. So if they do a scheme that's on the government, you're essentially already removing access to so many Filipinos whose nearest facility is the private facility. So essentially, that's what they're doing. But then they know that the private, unfortunately, are not as well behaved. So you need to make sure that they also buy into this, pay them properly, but at the same time, they make sure they don't abuse the system. Finally, I think the question was sustainability. So at the end of the day, it's finding all this money, right? Now, sometimes we could just say, oh, we could have the state health minister from Maldives just go to parliament and ask budget. Easier said than done, right? Because unfortunately, this is a social protection workshop. The Ministry of Social Protection in the other room is going to ask money as well. So as you ask money in health, my friend, my boss, Karen, is going to ask money for graduation, approach, or education. Education's not here. They'll also ask money. So we have to be candid about it. The fight on budget is going to be hard. And every sector will have a justification why they should be given the money, right? Even the culture and arts will have justification. So to expect that you will be prioritized in Parliament, is something nice to talk about, but at the ground, it's a hard fight. So one of the great things in health is that actually there are two mechanisms in health where you could mobilize money outside of the usual parliamentary process. One is health insurance. Health is one of the few sectors that's actually allowed to get earmarked because health insurance has been there. And the money even goes to a fund that is not the general fund. What's great about that? You don't have to return the money if you don't spend it. So that's the beauty of health insurance fund or whatever health protection fund. It's external to the general fund. You actually get to collect money already from the formal sector, best population to get money from because they're healthy and they don't use it. And just make sure that actually also helps the poor. That's the Philippine story. They collect now more money from the formal sector and they use a lot of that money to fund the poor because the formal sector doesn't want to go to hospitals or get sick. Eventually, they will become old, and that's a new challenge. Let the younger people worry about that, right? But in a sense, that's unique to the health sector. Education don't have that. Other sectors don't have that. The second, and what is emerging, and I will now respond to that, the beauty of sin taxes. Okay, so I was still in government. That's why she knows how to ask the question. So we tried to fight for increase in taxes. I was, even before, as a health person. We got pushback. Ministry of Finance say, why? You're going to affect the poor. That's regressive taxation. That was the answer. Those who were championing against increased higher taxes of cigarettes and alcohol, that's the answer. So we said, okay, let's make it into an elegant argument. So we say increase the taxes, but the taxes goes to health. So now you fight the regressiveness argument because say, look, okay, we admit it might be regressive, but whatever money we get goes to health. At the same time, we get the health benefit of lower alcohol, lower cigarettes, so people become more healthy. So that countered the argument. Now the second argument of finance was, but we don't want earmarking. Okay, that's against classical public finance management. Okay, so we said, okay, let's make it into a soft earmark. So essentially, what will be collected becomes the new target of health that they can fight in Parliament. So all of a sudden, health was getting only about 20 billion pesos. Since the taxes was 40 billion, automatically the target of health becomes 40. Because now you can target the tax collection level, and that has allowed health to increase the money so high now. So finance was happy with that, and there was an additional compromise. Whatever taxes you're collecting now doesn't get earmarked, so it's only the incremental that goes to health. So finance becomes happy. Okay, there was a third, but then they said, oh, but you've been getting money and nothing's happening. You've been building hospitals, you've been hiring people, all inefficient, right? So the answer was, PhilHealth, no, this is going to be different. The money will now subsidize people into a health protection scheme called the National Health Insurance Program. And it will subsidize the poor, people with disability, and not yet me, the elderly. So it has now a very powerful targeting argument. When all of this was presented to Congress, it was approved by one vote. Okay. Now the funny thing is the guy who, one of those who voted against it is actually running this country right now, but that's another story to tell. Okay. At the end, we just like to highlight, if you push social health protection, there's no one answer. It is not arguing, let's do health insurance. It's not arguing, let's do free healthcare. It's policy. It's making sure that the population is involved. It's making sure providers are involved. It's involving the private sector. And it's really being savvy to make sure that the money is there. End of the day, because we are going to be kicked out now, allow me this. We just went to a pandemic. And one of the great things, one of the few, probably the only good thing that happened, two good things that happened in the pandemic. More money went to health, and digital happened. So as we leave the room, I always love to say this, let us not waste the pandemic for all the gains it has given in improving social health protection. I think we need to get...
Yeah, wonderful closing remark.
Okay, thank you. Okay.
Thank you, everyone. Thank you.